Good afternoon, everyone, and welcome to this joint briefing of the House Health and Government Operations Committee. And we are joined by three members of the Appropriations, Health, and Human Services Subcommittee that is chaired by Delegate Resnick. This is a virtual briefing, as you know, and we ask for your patience if there are any technological problems. Committee members will be muted. If you have a question after the presentation, please use the raise hand function. Please adhere to our usual committee rules. This applies to our guests as well. Of one question and one answer from the panel, not one question and one answer from each individual panelist. Please keep your question shorter than the expected answer. Today we'll be briefed by the Maryland Department of Health as follow-up to our fall briefing on issues related to the department's administrative services organization, Optum. We will hear from Steve Hsu, who is the Deputy Secretary for Healthcare Financing in the department, and from Webster Yee, who is the Assistant Secretary for Health Policy at MDH. Chad Burkholder, the Chief Operating Officer of Optum, will be available for questions. That will be followed by a panel of providers. Deputy Secretary Hsu, please begin.
Can you hear us?
I can hear you now.
Great. Nice to see you. Thank you for having us today. Appreciate the opportunity to brief the two subcommittees on our progress with the Behavioral Health Administrative Services Organization. For the record, I'm Steve Hsu, Deputy Secretary for Healthcare Financing and Medicaid, and I'm the State Medicaid Director. With me are Webster Yee, Assistant Secretary for Health Policy, and as the Chairman just mentioned, Chad Burkholder, Chief Operating Officer for Behavioral Health from United Health Group Optum. Let me just mention that for more information beyond what we discussed today, please see our Joint Chairman's report on this subject, which we recently submitted. We characterize 2021 as a year of steady progress and continual improvement in our Behavioral Health Administrative Services Organization, or BASO, as we call it. We thank UHG Optum for its dedication to technical and process improvements, and our providers for their continued feedback. They have been wonderful. Since our update in November, the BASO has received and processed more than 3 million claims, which brings the total claims paid to 20 million since the start of the contract. Made over 600 million in payments, bringing the total dollar volume of payments to 3.2 billion to over 2,600 providers since the beginning of the contract, and continued to average 30 to 40 million per week in payments for actual claims for care since the beginning of real-time claims processing in early August of 2020. This is in line with historical averages. Next slide, please. Importantly, 98% of all provider claims are adjudicated within 14 days, well within industry standards. We continue to work with UHG Optum to assure that valid provider claims are paid accurately, consistently, efficiently, and transparently. With regard to accuracy, making sure that claims are properly processed according to the system rules and the clinical judgments contained within medical necessity criteria. In terms of consistency, making sure that claims with the same characteristics are processed in the same manner so that providers can resolve issues with their claim submissions. Efficiency, making sure that claims processing occurs with minimal human intervention and without additional inputs beyond those needed to process the claims. And finally, transparency, making sure that providers are given visibility into the status and details of their claims relevant to processing in a timely manner. We continue our regular provider and stakeholder meeting cadence that was started over 2 years ago, and since October, we added a twice-monthly provider leadership call with leaders in the provider community to share their issues and to enable them to ask questions. We continually seek to improve on identified issues in a collaborative fashion with all parties. Looking forward, we are intensely focused on four things: making continued system improvements to ensure that the BASO meets our previously described claims processing objectives, recouping overpayments and duplicate payments that resulted from retro eligibility claims and third-party liability claims that occurred last March. That process is beginning now. Commencing the recoupment sequence of the 2020 estimated payments in the spring of 2022. That amount is now down to approximately $215 million. We've reconciled or recouped more than 80% of the original nearly $1.1 billion. So we've come a long way. And initiating a request for proposal or RFP process to ensure that we are well prepared for the end of this contract in 2024. Next. At the initial launch of the UHG Optum system in January 2020, the system had technical and system failures that impacted behavioral health providers. As a result, MDH directed UHG Optum to make weekly estimated payments to behavioral health providers beginning on January 23rd, 2020, and continuing through August 3rd, 2020, based on providers' 2019 historical average payments. This resulted in a total of $1.06 billion in estimated payments over a little more than 6 months. As part of the reconciliation process for this period, UHG Optum and MDH worked over the past year to reconcile the $1.04 billion worth of provider claims against the estimated payment total. As I mentioned, over the past year, we've reduced the outstanding balance of overpayments to providers with estimated payments to approximately $215 million owed to the state as of January 25th, 2022, down from $360 million owed in October of 2020. Over 80% of the original $1.1 billion has now been reconciled or recovered from providers. 835 reports, which are electronic reports with claims and payment detail, and provider remittance advice, or PRA reports, were delivered at the end of October, but did not provide an easy way for providers to track a given claim through the system from start to finish, especially if it were denied and had to be reprocessed a number of times. A key reconciliation goal now is the Consolidated Claims History Report, which is projected to be in production by mid-February. UHG Optum senior management confirmed this date in a call with us just a few days ago. The Consolidated Claims History Report will enable providers, especially those with more complex accounting and claim systems, to review and reconcile their internal reconciliation between actual claims submitted and payments from the estimated claims payment period by allowing them to see the entire history of a claim from start to finish. Maryland has a responsibility to federal and state taxpayers to recoup the differences in the estimated claims and the actual claims submitted, and just as importantly, and maybe more, to channel those dollars back into much-needed services. As previously announced, in recognition of the challenges caused by repayment, MDH is forgiving 100% of amounts due for eligible providers with fully paid or still outstanding balances of $10,000 or less. As a result, more than 40%, or 895 providers with outstanding balances, will owe nothing. We believe this action will eliminate the burden on small community-based providers. All providers with fully paid or outstanding balances of $10,000 or less will have their balances cleared, with the exception of a few categories: hospitals, laboratories, somatic behavioral health providers, out-of-state providers, and providers who have not yet submitted claims against any of the estimated claims paid. For providers who owe more than $10,000, they will have one of three options for repayment: payment in full at the time of notice, a 12-month interest-free repayment plan, or the option to credit current claims paid to offset all or some of the balances owed over a 12-month period, with final payment to be completed in 12 months. We will formally commence the recoupment process for overpayments resulting from estimated payments this spring, and will work with providers over the course of the winter by sequencing our recoupment actions to enact repayment plans with all providers. We have Optum reconciliation managers that will work with providers in this process. There are several key components to the recoupment sequence. We're engaging in active discussions with provider representatives regarding possible partial forgiveness for providers with $10,000 to $50,000 in outstanding balances. We're also discussing possible partial forgiveness for providers that have already paid their outstanding balances of between $10,000 and $50,000. Providers that have submitted no claims against their outstanding balances were required to pay their outstanding balances on or before December 1st, but not later than December 31st. Providers who have not engaged with MDH's request for payment and did not meet this deadline have been sent to central collections. Providers that are in possession of duplicate payments will be expected to repay such payments on or before April 15, 2022. Providers with outstanding balances will be required to begin repayment of such balances at a date that will be announced in the spring. Once recoupment of outstanding balances commences, providers will have up to 1 year to repay in installments, again without interest. As part of this reconciliation effort, we have engaged the Office of Administrative Hearings, OAH, to assist with third-party mediation. A final memorandum of understanding is being prepared between MDH and OAH. The key lesson learned from the transition of the previous BASO vendor to the current vendor is that there was not enough time to design, develop, and implement the UHG Optum system thoroughly. The UHG Optum contract ends on December 31st, 2024. MDH is using the lessons learned from the current contract implementation, input from the behavioral health provider community, and the need to include an evaluation of past performance in similar contracts to begin the request for proposal, or RFP, and procurement process now. Our goal is to develop the RFP and to solicit bids in 2022, select a vendor, and begin design, development, and implementation in 2023. Provided the system is tested and accepted, it may be online as soon as the 2023-2024 time period. All competitive bids will be reviewed on a technical and financial basis in line with state procurement laws and regulations. We'll be sending out a provider survey later this year as part of the RFP development process. For more details, once again, please see our attached backup materials, including the January Joint Chairman's Report, which was published Monday. Thank you for the opportunity to update the subcommittees. Mr. Burkholder, Mr. Yee, and I would be happy to take questions.
Are there questions from members of either committee for this joint briefing? Delegate Valentino.
Thank you, Mr. Chairman. I didn't really want to go first, but I didn't see any other hands. Barry Hsu, and I'm trying to understand this, maybe one question. So, Mr. Chairman, if I start to exceed, just give me the flag, but I think I might have two. So, Mr. Hsu, or Secretary Hsu, I just want to understand, you started recoupment against providers in December. Is that correct?
In December, we started collecting monies that were overpaid for reasons other than the estimated payments period.
But
The estimated payments period collections won't begin until the spring.
So
But-
Delegate, if I may, the key distinction is in December, we started collections against people who basically had no contact with us,
No.
who had no engagement in the process.
Okay, so let me understand this. You said that you didn't expect Optum to be able to provide the providers with everything they need to decipher the validity of their claims, be it the 835s or the PRAs, until mid-spring. You said you expect them to have everything they need in mid-spring. So the providers, whether they contacted you or not, didn't have any of the reconciliation or
this
the validity
particular-
of the reconciliation information, because you're saying it won't be provided till February.
Yeah, this particular group of providers is unique because they submitted no claims at all during the period that's relevant. So that means all the money that was advanced to them was for no reason at all. They didn't perform any services. They probably went out of business, left the state, something along those lines. And having not submitted any claims at all back to MDH means they're no longer operating. That means all the money we sent to them is due back to the state.
Okay, I appreciate you
Okay.
clarifying that. And can I ask one more question, Mr. Chair?
Final question.
So you have this passion for protecting the taxpayer money. And I hear that in what you're saying, and I hear that in your statement that you have to be true to the taxpayer and you don't want these providers holding on to money that you don't feel has been justified. And I think the providers have testified to us that they understand that. But I'm not seeing in the report that you submitted on January 31st to the committee about the contract violations.
Can you ask your question, please?
So you have not executed the penalties and the damages and the contract violations to get the damages back from the Optum, which would also be preserving taxpayer money and a commitment to the authenticity of the money due to the general fund.
Delegate Valentino, I'll take this one. If you look at our pages 8 to 9, we lay out specific action items that we have done, which have included withholding payments to Optum. Now, if you're saying, hey, why don't we terminate the contract? Let's be very clear here. If we terminated the contract, we need to ensure that there is a system to pay these providers the $30 to $40 million a week. It would be, we believe, irresponsible for us to engage in litigious behavior if we have a system that's working. And we want our vision and our mission so far, and our actions have demonstrated, we believe in working with both Optum and the providers in a collaborative fashion, and we have done so over the past 2 years. So I don't think it would be a good idea to just launch into nuclear warfare with our partners.
I appreciate that. And thank you, Mr. Chairman. I wasn't suggesting nuclear warfare, but on pages 8 and 9, you admit that you failed to recoup liquidated damages for every day that they were in breach. Thank you, Mr. Chairman.
Thank you, Delegate Valentino Smith. Delegate Bagno, followed by Delegate Young.
Thank you, Mr. Chair, and thank you for this update. I'm just trying to draw the through line from the briefings in November and December to now. When you talk about the 100% of forgiveness on the communities that were $10,000 or less, is that the same population that in our previous briefing was sort of the over under, where we knew some providers in reconciliation were paid more than they were supposed to receive, some were provided less, and that the behavioral health community was asking for that population to be forgiven because it was sort of going to reconcile itself?
Delegate Bagno, I'm not sure I completely understand the question. We are, ever since normal claims payment commenced in August of 2020, we have been accepting claims from all providers and reconciling against the amounts that we had advanced during the estimated claims period. And that's what has resulted in a progressive decline to $215 million. So that they are getting credit for those amounts against what they owe, and the amount they owe is going down over time. Some providers are below $10,000, and our judgment was that the administrative burden on those providers and the generally small size and community-based nature of those providers did not justify the resources that would be required on our part and their part to collect those de minimis amounts of money. And that's why we went down the path of forgiving those amounts of $10,000 and less. And as I also mentioned, we are trying to consider whether there's a path forward to partial forgiveness for people who owe between $10,000 and $50,000, because in the absence of that, we have a cliff situation. Somebody that owes $10,000 is fully forgiven. Somebody that owes $10,001 owes $10,001. So we're thinking maybe some sort of sliding scale. Does that address your question?
It does. Thank you.
Thank you.
Delegate Young, followed by Delegate Krebs.
Thank you, Mr. Chair. And thank you for your efforts to try to correct many of the problems that have occurred with Optum. As recently as last night, I received a desperate 2-page letter from a mental health provider in my community with just a tale of woes about clients not being reimbursed, as well as their inability to get reimbursement to the point that they've suffered innumerable financial losses. What would you like me to tell them? How do you recommend I respond to them?
Delegate Young, I would ask you to please forward that communication to us. We take those very seriously. We will engage directly with your correspondent and work with the reconciliation manager at Optum to resolve whatever their issues are. As I mentioned in my remarks earlier, we are going to be, through Optum, on track to deliver a comprehensive claims report that will show the entire history of a particular claim from beginning to end, so that they can easily reconcile against their own internal provider records and get comfortable that the numbers are correct. But we would be happy to work with your constituent.
Thank you, and I'll take advantage of your offer.
Please.
Delegate Krebs, followed by Delegate Bhandari.
Thank you, Mr. Chair, and thank you for this comprehensive report. And my delegate before me asked some of my questions, but we're still going back to the recoupment process. And I've got a ton of letters from my providers as well. They're all in distress. They went from a system they loved. They had an assigned person at Beacon. Everything worked out. People knew what they were doing, and they now have a different person every time they call that does not seem to be knowledgeable about what the claims are. But the particular question has to do with the recoupment process of the estimated payments with Optum. Optum required supposedly them to sign an agreement to pay back the amount they determined that they owed without providing any ability for them to see the Medicare and Medicaid transactions. And they were basically told that they had to sign it or they weren't going to get it back. So they were asked to sign a contract on something and they didn't really know what they were signing for. And I'd like to know, for this recoupment process, how are you supposed to have some transparency so the provider knows what they're being recouped for?
Well, thank you, Delegate Krebs. That is precisely the purpose of the comprehensive claims report. We do understand that the 835s and the PRA reports were tantamount to throwing a bunch of puzzle pieces on the table and asking the provider to try to reconcile all those little puzzle pieces against their own internal records. It just wasn't going to work. So we worked with Optum to develop this comprehensive claims report that will take a given claim, even if it had multiple claims numbers over a very long period of time because of resubmittals or other issues, and consolidate all that information onto a single report. And that should give us blue skies. That should give the providers blue skies to get comfortable that these numbers are in fact correct. And if they're not, we're going to work with them individually, claim by claim, to get the numbers to where we are mutually agreed.
And that is right, you're going to go back to the, I mean, I assume what you're talking about, you're going back to the recoupment process, not just moving forward. And then will there be any reimbursement to these claimants for all of the administrative work, the hours and hours and hours that they've had to put into this over the last year? I mean, is there any reimbursement for those administrative hours that they've had to put in?
Well, that
Delegate Chris, if I could just touch back and finish up our answer. To our knowledge, there is no such requirement of a provider having to sign something. If your provider can provide an example of that, we'll be happy to look into this. To your question, to your second question here, I think the key point here that we want to be very careful of is with the recoupment, that is for the estimated payment period from January 2020 to August 2020. That is phase one. Phase two, which is the actual claims processing system, has been underway. As Mr. Hsu said, it has been working with very good success. He put up the metrics, and we believe that the system is working as designed right now. And so we are now gently going back into phase one and working through it with all of our providers. And again, we're trying to make sure that we are able to submit the claims, get them lined up, get things reconciled so that we can get the federal match.
Thank you. I will follow up with you specifically. Thank you.
Thank you.
Delegate.
And I think,
Go ahead.
sorry, Mr. Chairman, go right ahead.
Delegate Bhandari.
Thank you, Mr. Chair. And this question is to Deputy Secretary Steve Hsu. Following up on Delegate Bagnall's question, how did Maryland Department of Health land on recoupment forgiveness for $10,000 for 40% of all providers? Why not leisure more? What was the rationale?
We spent a lot of time internally discussing where to draw those lines. There's no stone tablet to guide us to the right answer on something like that, Delegate. We made a judgment based on the administrative costs to providers of reconciling these small claims, the challenges to the department of trying to collect these small claims, and we felt that at the same time that we shouldn't overdo it with respect to forgiveness, that it should be a manageable amount that wouldn't materially reduce the amount of money that the state ultimately collects. For the reasons I said a moment ago, we do have a responsibility to taxpayers, but more importantly, at least in my opinion, the money we get back from these overpayments, these dollars to which people are not entitled, is money that we can channel into services. And all of you know very well, people need these services, and the more money we can put at services, the better off everyone's healthcare will be. So I can't say there's a lot of magic to that number, a lot of science to that number, Delegate. It felt like the right size based on the total financial impact on the dollars we would ultimately collect, and also the amount of administrative burden on the providers and on the state to collect amounts of that size.
Thank you.
Thank you.
Thank you. I would just remind the members that Mr. Burkholder, the COO of Optum, is available for questions, but seeing no digital hands raised, we will proceed to Gregory Hook, who is the Chief of the Office of Legislative Audits. Mr. Hook. Is Mr. Hook in the waiting room or?
Delegate Rosenberg,
Yes,
this is staff, Aaron.
yes, indeed.
Our panel is the next panel, Lori Doyle. It's
Oh,
agenda-
it's not on my document. I'm sorry.
Your agenda.
Okay, we'll then hear from providers. If those providers could speak, identify themselves and then make your presentation.
Thank you, Mr. Chairman. Lori Doyle here on behalf of the Community Behavioral Health Association of Maryland. And I have with me Lauren Grimes, also from CBH, to answer any technical questions that the committee might have, and Karen Carloni, who's the Executive Director of the Southern Maryland Community Network. And I'd like to start by thanking the committees for your ongoing attention to Optum's lack of performance. The impact on providers has been enormously disruptive. I'd like to thank the department and Optum for their ongoing meetings with us. Unfortunately, if you have a flawed platform, no amount of goodwill and hard work will fix it. And I'm afraid that's where we are. So if I can go to the next slide, please. So just a quick reminder of how we got here. When Optum went live on January 1 of 2020, their system immediately failed. The department was forced to make advance or estimated payments to providers in order to keep them afloat. And those payments lasted from January of 2020 through August 3rd of 2020. The estimated payments were based on 2019 claims history. It's important to remember that COVID hit right in this beginning of 2020 when the estimated payments started and caused major disruptions to service delivery. Next slide, please. So just wanted to give you a quick update on Optum's current functionality. Unfortunately, their system continues to be unequal to the task of authorizing services and paying claims accurately and within contractual timeframes. Claims continue to be processed and reprocessed multiple times, and a new claim number is assigned each time. So this not only inflates Optum's data about the volume of claims that they have processed, but it's also critically important because it will come back to haunt us with the recoupment process that we're now facing. So although there are ongoing functionality problems, our focus here today is on recoupment because it is imminent and potentially very damaging to providers. Next slide, please. So we're now facing the payback time. What do we owe? Please keep in mind that this whole process of recoupment only exists because of Optum's shortcomings. We acknowledge that we need to pay back the duplicate payments. Optum messed up. They paid us twice for some things. We absolutely agree that these must be paid back. So that leaves these other recoupment buckets that the Deputy Secretary alluded to that are associated with other problems that Optum created because of the shortcomings of their system. But what is included in these buckets of recoupment keeps shifting, and the amounts that providers owe keep changing. So providers received demand letters in early December of 2021 and were given an amount that they supposedly owed for the first bucket of recoupment. However, we later found out that the amount providers were given was understated because it did not include everything we were led to believe that it would. So a provider may have gotten a demand letter for $50,000, which is congruent with what they think they owe in total, only to find out that yet another $40,000 is not included in that amount, but needs to be paid back. Next slide, please. You may recall this from an earlier briefing, and for some reason, the whole thing is not showing up correctly. But CBH's proposal to the department was that we pay back all duplicate claims. As I said, we know we owe those back, we pay those back. Optum needs to agree also to process all the claims that have been sitting in their system since the estimated time period, again, early 2020. These claims were lost in Optum's system or erroneously denied. They're still sitting there unpaid. So if those two things happen, that leaves the variance between estimated payments and the actual services rendered in that first 8 months of 2020. Now, the variance is created because the estimated payments were based on 2019, COVID hit, and service delivery dropped in a lot of cases. Some provider groups like long-term care, developmental disabilities, were shielded from the impact of COVID through what were called retainer payments, but behavioral health providers did not have access to those. We asked the department and were told that we received estimated payments instead. And yes, the estimated payments kept us afloat, but unlike retainer payments, we have to pay those back. So again, this is all due to Optum's dysfunction. And so we ask that there be consideration of debt forgiveness beyond the small allowance the department has made for providers owing $10,000 or less, because this has hit everyone across the board, small providers, large providers. Next slide, please. Finally, I will close with this slide by saying that the recoupment process must be accurate and transparent. Optum still has not provided a full claims history report, so providers can track the multiple processing of individual claims. Without that, we cannot check Optum's math in terms of what we owe, nor can we determine what claims our repayments offset, so we don't end up paying for the same claims over and over again. You've heard that this report is coming. Given some of the past promises, we don't hold a lot of optimism, but we're hopeful. But this is like, you're getting a credit card bill that says you owe $10,000. There's no itemization of charges. There's no itemization of any payments you've made. And then the following week, you get a new statement saying you now owe $15,000. That's not the way this should work. You'll be seeing legislation this session to address provider concerns about recoupment. It's HB 715. Delegate Valentino Smith is sponsoring, and Senator Augustine on the other side. So I'll stop there. And with your permission, Mr. Chair, I'd like to turn this over to Karen Carloni, who can describe the impact Optum has had on her organization. And unfortunately, hers is only one of many. Thank you.
Thank you. Next witness.
Good afternoon, Mr. Chair and members of the committee. My name is Karen Carloni, and I am the Executive Director of Southern Maryland Community Network. Our agency has been meeting the mental health needs of individuals living in Calvert, Charles, and St. Mary's counties since 1981. We employ 71 individuals and serve more than 1,000 people every year with a variety of programs and services. Optum is the fourth ASO vendor I have worked with in my 22 years of service with the agency, and the scale of problems is simply without precedent. As a board member of the Community Behavioral Health Association of Maryland, I'm sadly aware that our concerns are not unique. I appreciate the opportunity to outline the 4 areas of concerns that I have. Number 1 is the reduced ability to fill service gaps. Last year, we received a state grant that would allow us to double the capacity for residential crisis services in Southern Maryland. For almost 6 months after meeting accreditation requirements, we couldn't admit a single person because Optum failed to set us up in their authorization system. We were days away from losing our license and accreditation before we were able to get Optum to complete this step. To date, we have not had a single claim paid for that program. In addition, we have had significant issues requesting concurrent authorizations for those who require a longer stay. The direct manager of that program quit because she feared the lack of reimbursement and licensing and accreditation timeline issues were putting her job and the program at risk. My second area concerns underpayment and non-payment. Historically, my agency runs a balance of about $300,000 in our accounts receivable. Due to the underpayments and delays, our current accounts receivable is 5 times higher at $1.5 million. We have spent over $20,000 on a contract with a former ASO executive to try to make sense of our Optum claims data and reports. She and her data experts say that the reports don't have the data she needs to accurately track what's happened to our claims. We have over $70,000 in 2019 claims from the previous ASO that Optum acknowledges should have been paid, but have not been. Our best estimate is that the effect of the total recoupment will be about a 50% reduction in our cash reserves. About 1/3 of that is attributable to duplicate payments. Whether or not this amount matches what Optum will expect to recoup remains in question. As a result, the third area that I'd like to bring up is the stacking of additional expense and administrative burden on a workforce crisis. As a result of Optum payment problems, we have implemented cost-saving measures, including laying off senior staff and redistributing their duties to remaining leaders. Our experienced billing manager quit, saying she couldn't tolerate the stress of untangling the claims and payments. We're facing unprecedented direct care vacancies and turnover due to pandemic burnout. Staff development, attraction, and retention are taking a backseat to addressing claims and payment issues. The final area I'd like to discuss is financial destabilization. Because of the financial and operational confusion that Optum has caused, we can't track staff productivity or predict cash flow accurately, which is negatively affecting our ability to manage the agency in a fiscally sound manner. For the first time in our history, we received a qualified audit opinion due to Optum's payment practices, which damages our ability to fundraise and compete for state grants and contracts. We delayed our 2021 audit in hopes that the situation would resolve, but we expect another qualified opinion for 2021. Reduced ability to fill service gaps, underpayment, non-payment, expense, and administrative burden, in addition to financial destabilization, are putting jobs at risk, services at risk, and Southern Maryland Community Network is not alone. I urge you to consider implementing debt forgiveness measures for the portion of overpayment not attributable to duplicate payment. The financial and operational recovery of the mental health safety net needs to begin as soon as possible. Thank you.
Thank you, Ms. Carloni. Ms. Grimes, you are available for questions, is that correct? But no statement.
That is
All right.
correct.
Thank you, thank you. Are there questions from members, from the legislators? Ms. Delegate Bagnall.
Thank you, Madam. Thank you, Mr. Chair. And thank you for this presentation. I think this question is for Ms. Doyle. Within the CBH membership community, do you have an estimation of the outstanding unprocessed claims and how much of the variance population that was identified on page 5 that we heard about in previous briefings, how much of that population are captured in that $10,000 or less provider population that were given forgiveness?
Delegate, if I may, I'm going to toss that over to Lauren. She may have a better idea of those numbers. Thank you.
Hi, thank you for your question, Delegate Bagnall. I think the accurate answer to your question is 0. None of the CBH members fall within the forgiveness tier for estimated payments. There is no member of the 90 that we represent that I know of that owes less than $10,000 for the estimated payment of recoupment.
Delegate Kelly.
Thank you, Mr. Chairman. I think my question also is for Lori, but you can direct it to whoever you think is appropriate. I cannot help but make this connection after hearing these stories. And like Delegate Lewis Young, I have also heard from my own constituents who are really struggling with Optum and getting their payments processed appropriately. And I can't help but make the connection between that and the same administration that is trying to, is coming to us about a behavioral health care shortage in licenses and trying to really make it much easier for folks out of state to work here. So do you find that maybe, I don't know how to ask this the best way that you can answer it, but really, it's very interesting to me that we're having difficulty paying our in-state providers, and yet there's this push to allow more out-of-state providers. Is that something that you've thought of? Is that something that you can help me understand? Should we be allowing folks from out of state when we can't even pay our hometown folks who are providing this care already?
Well, thank you, Delegate, for the question. I think we would absolutely prefer that we be on firm financial footing to pay the clinicians and the staff that we have right now. And of course, a lot of our staff are not even licensed clinicians. They are paraprofessionals. And so we would not be helped with any out-of-state activity anyway. But with the out-of-state, there's certainly questions around quality and what happens if something goes wrong. So I think we would prefer to have our own clinicians and have them paid well.
Thank you very much for your answer. I appreciate it, and for the work you do.
Thank you.
Delegate Krebs, followed by Delegate Valentino Smith.
Mr. Chair, I hope this is appropriate, but I wanted to ask Mr. Burkholder a question. He was on the previous panel available for questions. But now that the providers have spoken and you've heard specific examples of what their issues are, and I've got a bunch I'm going to send over to you from my providers, can you give us any confidence specifically of what you're going to do different after hearing from these providers? How are things going to change from this day forward? Because we're still having problems from our last conversation, but what do you propose to make us feel comfortable with that we're going to get to the bottom of this?
Mr. Chairman,
Yes.
I'm going
Thank
to
you.
ask that you allow this because I think that what we're hearing today is completely shameful. It almost sounds like it's either incompetence or somebody trying to put our local providers out of business. And in either case, I think we really need to hear from the perpetrators.
Indeed. Mr. Burkholder.
So I'm happy to engage in the dialogue. So there's a few things that I would address. So one, I think it's very important in Deputy Secretary Shu's comments and Assistant Secretary Yee's comments, they separated it into two elements, which is very important. The current status of payment on claims submitted in the current times, we have a high degree of confidence today. We think the quality of those outcomes are appropriate, and we think that the amount of cash flow is in direct alignment with the state's expectations of policy procedure. And in the cases where there are significant challenges, we're working actively to understand either A, how a provider can submit the claims in accordance with state policy, or if there are particular systematic challenges that are experienced, then we try to work very immediately to resolve those right away. So we believe that in terms of current state, how things are functioning today, post-August of 2020, we feel very confident that the current approach is functioning as it should. I think the frustration that certainly I hear from the provider community, frankly, I have the same frustration as well, is it really is hard work to clear up and address the challenges of January through August of 2020. Fully acknowledge that. I would say that we've actually had some really good successes with some very meaningful, very large providers in the state of Maryland who've actually completely resolved their estimated payments reconciliation, even without some of the tools that have been discussed. And so certainly their sophistication might assist with that, but I do believe that that also demonstrates that the degree of data challenges, we're working hard to overcome those, both through our own engagement as well as through the providers. So we appreciate that. So the other element that, sure, the only last element that I would just mention is that some of the items that have been referred to in terms of wide numbers of claims being withheld, absolutely acknowledge what Ms. Doyle referenced in terms of the Beacon historical claims, working quickly to resolve those. That's right around $3 million in total. And the current coordination of benefits and third-party liability claims, which are also a pocket of claims that are needing to be addressed, is around $200,000 to $300,000. So while I absolutely acknowledge that there are elements that need to be addressed, we need to continue to speak in terms of context of size. But I will say that that we genuinely appreciate the engagement of the provider community. We're trying to work very actively with them, including most recently, and Ms. Doyle referenced the claims lifecycle report. We did in fact publish a claims lifecycle report through a pilot program with key providers, and they offered excellent feedback, asked for additional enhancements. The only reason the claims lifecycle report has not been released is because we have been adopting the feedback of the pilot community and then incorporating that into our release, which will happen later this month, as Deputy Secretary Shu outlined. So I would close by saying we thank the state, we thank the providers for their engagement. We too are frustrated with how this has progressed. This is not how we ever intend to see an engagement go, and we're committed to making sure we address the challenges and move ahead.
Thank you. I hope you take care of 100% of our providers in a very tight time frame, because we still have a lot of issues out there. But thank you. I'll follow up offline.
Thank you, Delegate.
Delegate Valentina Smith, followed by Delegate Kerr.
Thank you, Mr. Chairman, and I really want to commend your committee for continuing to have these hearings with all of us so that we can have everybody online and and understand what's going on in real time together. So with that, the department is submitting these quarterly reports that they submitted to us. And so I guess this is for Lori, trying to understand. On page 7, the department is saying to us, as of the end of October 2021, all missing 835 reports and provider remittance advice have been delivered to providers by Optum to facilitate their record keeping and reconciliation of estimated payments made between January 1, 2020 and August 3rd, 2020. So we're kind of being told here today as the update that all missing 835s and PRAs for that time period have been provided. Is that the case? Is that where we are right now, Ms. Doyle?
May I defer this to Ms. Grimes?
Certainly.
Thank you for your question, Delegate Valentino Smith. And I believe the answer is no. As of the end of October, there was a large remit of the missing 835s that providers did receive. Subsequent to that, in the week that followed, there were a number of providers who reported 835s that were still outstanding. The week after that, at our biweekly meeting with Optum and MDH, Optum indicated that there was still about 10,000 that they had identified that had not been remitted. They were intended to be remitted, if I am not mistaken, the second week in November. We did have providers receive some more at that time, but even post that date, we have had 3 or 4 identify 835s that are still missing. About a month or a month and a half ago at that biweekly meeting, Optum had indicated that they are now, the amount of 835s is small enough that are still outstanding that they will be relying on providers to identify the missing 835s, and then they will remit them after they have reported them missing.
Thank you. Thank you, Mr. Chairman. I just remain concerned that we receive these updates where the department is making attestations to us that I have to assume they believe, but are completely inconsistent with the reality. Thank you.
Thank you. Delegate Kerr, followed by Delegate Kaiser.
Thank you, Mr. Chairman. Delegate Bagnall had asked this as part of her question. I don't think she got an answer, and Lori Doyle kind of alluded to it, but do you have an estimation of the amount of unprocessed claims, the dollar amount of the unprocessed claims? Anyone?
And I will defer to Lauren. I don't know if we have an actual amount.
Delegate Kerr, I'm interpreting your question to be the number of claims that are in a denied state inaccurately from the estimated payment period. And if I have that correct, I think the answer is we don't know. That there are the vast majority of the 90 members that we have still have a slew of them from the estimated payment period from January to August that are in a denied state, that are inaccurately in a denied state, and the reconciliation process that has been laid out by Optum and MDH using reconciliation managers is extremely slow going. So there is progress being made, but we're nowhere near to overturning all of the incorrect denials that exist for that period.
Thank you, Ms.
Delegate Kaiser, followed by Delegate Hill.
Thank you, Mr. Chairman. And yes, my seatbelt is off, everyone, but I am in my driveway at home. My question to Ms. Doyle and to the other providers, when the problem started happening and you started calling Optum and you started calling the state agency, what kind of responses did you get, and where was the state in helping you solve this problem?
So the response has largely been that things are okay. Things are fine. They're working well. We're processing claims. You've seen the charts yourself, the volume of claims that are processed. And it's almost a tale of two worlds. Optum is saying this, and we know what we're going through. We know it's not provider error. We've been doing this for a long time. And we know that there's a lot of manual processes going on at Optum that certainly create more errors and more problems. We know the timelines are not being adhered to. So it seems as if the response that we're getting is look at the volume, look what we're doing, but the reality from us is very, very different.
And then when you reached out to MDH, were they in support? Were they able to provide any help at all?
I mean, they meet with us regularly, and we talk, and we are, you know, very clear about the things that we're experiencing. I really do believe, and I know I said this in the very beginning, the platform, Optum sub-vendor, has a platform that is simply not up to the task. And it doesn't matter how hard the department or anyone else tries to fix this, they're not going to be able to fix it. So they're either stuck with replacing the vendor, or we continue to limp along.
Delegate
Okay,
Hill.
thank you.
Sorry, Delegate Hill.
Thank you, Mr. Chairman. Thank you all for being here today. Mr. Burkholder, let me ask you, it's probably a direct follow-up to Delegate Kaiser's question. We have these briefings, feels like, you know, every 6 weeks now. And every time we get a story from the folks having the lived experience, the companies trying to do the work and keep the roof over their heads and keep their employers employed, that is in stark contrast to what you seem to understand to be going on. What I would like to know is, why do you think, I mean, do you think that the providers are misrepresenting or lying about their experience? Or what is the problem that we get the complaints and our constituents are telling us, and people we know are verifying what we're hearing here? You all aren't getting it. And how do you plan on changing your survey methods or your outreach so that, I'm going to suggest, you're not getting the full picture? So how are you going to start getting a better picture so you can start addressing the problems in a way that actually impacts and helps us to help them to do their job and stay in business?
I absolutely understand the importance of the question, Delegate. Thank you for it. And I would never assert that our provider partners are intentionally misleading, lying, or anything like that. That is in no way, shape, or form, you know, our position. Frankly, we recognize the importance that they play in serving Marylanders, and our entire intent is to enable. That makes this situation very frustrating for all, including us. And so it's only with respect that I would say that our intent is to enable. But what I would say is that I think that the scale of the challenges they've outlined are real. I'm not going to, Ms. Doyle referenced a particular example. I'm not going to deny that example is not correct. I think the question is, what is the scale of those challenges? And what is being asserted is that there are, quote unquote, wide scale failures of the system. And upon factual review, you come to find, and I certainly don't want to minimize, because, you know, in the end, $100,000 here or $30,000 there is meaningful to in a significant way. But in a program that has paid the $3 billion that Deputy Secretary Hsu mentioned, the $3.5 million I referenced earlier in terms of Beacon historical and third-party liability items, is important to keep in context. The other element here that I do want to, that I feel compelled to offer up in defense of my own organization, is we very generally reference that the failures are, quote unquote, Optum related. This is an entire system, and we're working together across Optum. We have specific challenges and issues we have to address. The state has particular challenges. For example, we've worked hard with the state on third-party liability improvements in data to address those issues. It is an ecosystem, and there is joint ownership, but we, Optum, recognize that we have to be central to driving those solutions. So I want to make sure that there is some of that context. And then finally, the only thing I can say, Delegate, is as has been the case every time, our provider partners have been thoughtful and eloquent in their comments. I don't debate it in the least. We ask for their ongoing partnership and to also keep in mind the context and scale of this particular challenges that we're trying to address item by item. I hope I'm addressing your question, but we will continue to be very active and engaged with our partners at the state, MDH, as well as with our provider partners.
Mr. Chairman, may I follow up?
Well, let's move forward with Chair Pendergrass.
Thank you, Mr. Chairman. I'm sitting here listening to this, and it's at least somewhat refreshing to hear you admit to some extent that there have been problems. The problems that may be small to you are very big to small businesses, and they're very serious to the clients that they're serving as well, because if they're not able to serve their clients, then we have a crisis in the behavioral health community of people not getting the help they need. In the end, however, the responsibility for all this, we pay you to do a job, but it's the Department of Health and Do It who are responsible for this. And so you're taking the fall for this, and to some extent rightly so. But this is way worse than the health benefit exchange that we implemented originally before people were really very good at doing these computer things. And there was a lot of flack about the fact that that had to be redone. Frankly, this is in some ways a much worse disaster. Maybe it's a smaller population of people, though I'm not sure of that. This is as bad an incompetence or something that I've ever seen, something more bad than incompetence. And for me, incompetence is pretty bad. I'm appalled, and I'm especially appalled that the department comes back every time, and you too, and tell us that things are better and we're almost there and we're really working hard. I think there was a President Bush that talked about it's hard. Well, you got to get the job done. There's a lot of money been invested. There's a lot of people's time and energy being invested, and the department needs to step up and get this fixed. And I'm getting pretty tired of having to tell you these things. I don't think there's really a question there, but feel free to answer anyone from the department who wants to. Yeah. I think you can call on the next person, Mr. Chairman.
Thank you, Madam Chair. Delegate Kaiser.
Thank you, Mr. Chairman. Very quick for Ms. Doyle or the others. For all that you've heard today of improvement from Optum, has there been any evidence on your end of any improvement?
It feels as if we fix one thing and then two others break. So it's almost the game of whack-a-mole, where you feel like you're close to something and then something else goes wrong, or something starts to work for a while and then it breaks again. So we're still left with providers doing an awful lot of cleanup behind Optum that they simply don't have time or the money for, when we really need to be focusing our attention elsewhere.
Thank you. Delegate Jocelyn Pena-Melnick.
Thank you, Mr. Chairman. I really appreciate it. So this question is for the department. Are you having the weekly meetings with the providers?
Yes.
And these issues that have come to light today, have they not come up during these meetings? And if so, what have you done to address it? And is it time to maybe bring someone else to mediate?
Madam Vice Chair, when you say these issues, I think I'm a little bit unclear. We have steadily worked through issues that our provider colleagues and Optum colleagues have brought up. And over the past 2 years, I think we can credibly point to a long list of joint accomplishments that we've done in partnership with both parties. If when you say issues, you mean, are we agreeing to forgive $200 million? I don't think that is within our ability to forgive. That is ultimately a budgetary decision for the budget committees to have a discussion about.
To do cleanup. May I, Delegate Rosenberg, Chairman
Please,
Rosenberg?
Certainly.
For Ms. Doyle, have you been attending these weekly meetings?
Yes, as is Ms. Grimes.
Okay, and what can you tell us about those meetings?
They're collegial. We put issues on the table. Unfortunately, we never seem to get to the end of the fix. So it's a lot of, we'll take it back, we hear you, we'll take it back, we'll try to work on something, and nothing comes of it. So we wait and wait. That's why we're a little skeptical of the full claims history report. We've been hearing this stuff for 2 years now.
And Delegate Rosenberg, just one final, if I may. So what will you say, Ms. Doyle, to what Mr. Yee just stated, that they cannot, they cannot forgive $200 million? What will you say to that?
I would say that this problem was not of our making, that, if it were up to me, it would come out of Optum's budget, frankly, but it's not. I know who can't afford it, and that's the provider community. And I can tell you they are reeling. The providers are exhausted. These 2 years between COVID and Optum have done them in. And I know even the private providers, the individual providers who I don't represent, are dropping Medicaid. They're not seeing Medicaid clients because of this. And so we've got a growing need and a provider problem.
Thank you. Thank you, Mr. Chairman, for the flexibility.
Thank you. If I may, just to summarize, I felt as if I was hearing testimony from two different universes at today's briefing. We will resolve to the best we can at the bill hearing on House Bill 715 in the near future. Seeing no further questions, this briefing is adjourned. Thank you all very much.